Thank you. और लेजर इसी से चलता है ये वाला ठीक है थैंक यू So today is the last class of CVS, okay? What are the two topics that we'll be studying today? Cardiomyopathy and pericardial diseases. So cardiomyopathy, this is your competency. You have to know how to classify, describe the etiology, types, pathophysiology, pathology, gross and microscopic features, diagnosis and complications of cardiomyopathy. So how is it defined as? Why is this important now? तुम्हारे लिए जो important है वो बता देती हूँ. ये long question आ सकता है. Classify and describe the various types of cardiomyopathies. Okay? This can be a long question. In that, what will you do? You will give the definition, what I've written here. Then you will describe the three types that we'll be subsequently discussing. Okay? और सबका etiology, pathology, pathogenesis, clinical features and morphology सबकी लिखनी है. Okay? Of all three types of cardiomyopathies in your 10-mark questions. And each of these dilated, restrictive and hypertrophic cardiomyopathy में तीनों 5 marks के आ सकते हैं. Okay, exclusively either dilated or hypertrophic or restricted. 5 marks. In that you have to describe accordingly etiology, pathogenesis, pathology, morphology. All right. So what is the definition? बहुत हिम्मत है, बहुत हिम्मत है. प्रकृति उनको बोलो बच जाने के लिए and not to disturb the class. Okay, so how it is defined as? Cardiomyopathies are a group of diseases. It's there in the name. It affects the myocardium. Okay, it is associated with mechanical and or electrical dysfunction that usually exhibits inappropriate ventricular hypertrophy or dilatation. Okay, these can be confined to the heart or it can be a part of the generalized systemic disorders. Now, how will you classify this? According to the etiology, everybody knows primary or secondary. Primary का क्या मतलब होता है? Myocardium is affected first. Secondary, it is a part of a systemic disorder. According to the anatomic and functional abnormalities, this is what I was talking about. It is divided into dilated cardiomyopathy, hypertrophic cardiomyopathy and restrictive cardiomyopathy. Dilated cardiomyopathy is the most common of all the three types of cardiomyopathies. Now what is dilated cardiomyopathy? It is characterized by progressive Progressive cardiac dilatation. It's there in the name again. Okay. And what three things that you have to remember about each of the cardiomyopathies. This is caused by cardiac dilatation. Again, it's there in the name. Another thing that you have to remember, that it causes systolic dysfunction. Okay? It causes systolic dysfunction and there is hypertrophy associated with it. So what is the pathogenesis? Usually DCM जब तक हम उसको डायग्नोज कर पाते हैं बहुत ज़्यादा आगे चला जाता है, इसलिए उसकी etiology, exact etiological agent पता नहीं कर पाते. So but still we'll obviously find out what the etiology is. It's most commonly genetic. Okay, it is familial in 30 to 50% of the cases. It is because of mutation that involves more than 20 genes, specifically the genes encoding the cytoskeletal proteins. अब एक important protein है, gene है जो तुम्हें याद रखना है in the case of dilated cardiomyopathy is this TTN gene, which encodes titin protein. Okay, this is involved in dilated cardiomyopathy in 20% of the cases. Can be asked as a NEET question. Okay, autosomal dominant pattern is the most predominant pattern. It can occur because of myocarditis. Myocarditis because of viral myocarditis like Coxsackie B and other enteroviruses. Moreover, these infectious myocarditis then progresses to DCM, that is dilated cardiomyopathy. Okay, and how will you find out that it is because of viral etiology? Viral etiology कैसे पता चलेगा? It's written here. Because of elevated antiviral antibody titers. Okay. Alcohol. हाँ, ये भी एक question आ सकता है in your NEET question. Dilated cardiomyopathy is involved in which all conditions except, या तो it's most commonly caused by what? Okay, alcohol is one of the major causes of dilated cardiomyopathy. Thiamine deficiency is also involved, also causes dilated cardiomyopathy. Another NEET question. Okay, they can ask you कि thiamine deficiency causes which type of cardiomyopathy. Okay, very heart disease जो होता है वो dilated cardiomyopathy होता है. Now childbirth can also cause, it can happen late in gestation or several weeks or months postpartum. The etiology is multifactorial, and recent work have suggested that the primary defect in is microvascular angiogenic imbalance within the myocardium, leading to functional ischemic injury. That ultimately leads to dilated cardiomyopathy. Iron overload is another cause. How does it cause this? Is it interferes with the metal dependent enzyme system. Okay, and it can also cause injury by the iron mediated production of reactive oxygen species. Okay, ROS जो होता है, that can produce iron and that can cause damage to the myocardium, and that can cause dilated cardiomyopathy. Again, stress, which can happen because of persistent tachycardia, hyperthyroidism during development, or because of excessive catecholamines in the case of pheochromocytoma. How does this cause cardiomyopathy? It can cause because of direct myocyte toxicity or because of focal vasoconstriction, which is caused by these catecholamines that are secreted in stress. What is the morphology? Characteristically, it's written in the name, it's dilated, so heart will be enlarged. But एक चीज है, the heart will be flabby with dilatation of all the ventricles. Because of the wall thinning that occurs, it causes, there is a wall thinning that accompanies dilatation, and the thickness may be less than or equal to normal. One important thing in this is, because of dilatation of the heart, there is, what did I tell you? What is the dysfunction this has? Systolic dysfunction, है ना? Systolic dysfunction मतलब contraction में problem है. तो contraction अगर नहीं हो रहा है, blood निकल नहीं रहा है body से, तो what will happen? Blood वहाँ जम जाता है, and it causes this mural thrombi, again causing complications of thromboembolism. Okay. Now, this is the gross picture. ये normal है. Okay. This is the normal heart, and this is the dilated cardiomyopathy का heart. All four chambers are dilated. You can see it here very clearly. All four chambers are dilated, and look at how thinned out these ventricular walls are. Okay, compared to the normal, how thinned out these are. These are also prone for rupture. Okay. Now here is the histological picture. You can see that these individual myocytes have enlarged. Okay, and there is, what is this? Blue fibers क्या है? Interstitial fibrosis. Okay, this is not an H&E stain section. This is a Mason trichome stain. Okay, that highlights these collagen fibers in between the myocytes. All right. So histologically, we don't have any specific features that can tell us that ये dilated cardiomyopathy का biopsy है. An exception is iron overload. Iron overload में अगर हम Prussian blue staining करेंगे तो हमें iron दिखेगा inside the myocytes, saying that iron overload was the cause of the dilated cardiomyopathy. This is the only etiology that we can pinpoint on histology. What are the clinical features? It can occur at any age, but it is diagnosed most commonly in between the ages of 20 to 50. How will it manifest as? Slowly progressive heart failure, dyspnea, easy fatigability, and poor exertional capacity. The fundamental defect in dilated cardiomyopathy is ineffective contraction. That is nothing but systolic dysfunction. Okay. Cardiac ejection fraction will be less than 25%. Okay. Half of the patients will die within 2 years. Death is because of heart failure or arrhythmia. Cardiac transplantation is the only treatment. But sometimes nowadays an implantation of a long-term ventricular assist devices are being used. Now, hypertrophic cardiomyopathy. ये हमारे टाइम में बहुत कॉमन नीट क्वेश्चन हुआ करता था. 25-year-old football player collapsed on the field. What could be the reason? Okay, it used to be most commonly because of hypertrophic cardiomyopathy. It was a neat question at our times. I don't know it coming nowadays, or they have changed it. Hypertrophic cardiomyopathy is characterized by myocardial hypertrophy, defective diastolic filling, and ventricular outflow obstruction. What happens in this? The heart is thick-walled, heavy, and hypercontractile. Systolic function is preserved, but diastolic dysfunction is there. Now, dilated cardiomyopathy में क्या dysfunction था? Systolic dysfunction. Heart बड़ा हो गया है, अच्छे से contract नहीं कर पा रहा. Hypertrophic cardiomyopathy में क्या है? Heart has gotten hypertrophy, तो वो properly relax नहीं कर पा रहा. Okay, so there is diastolic dysfunction. What is the pathogenesis? Now, उसमें क्या था? What was the pathogenesis in that? Which is that one gene I asked you to remember? TTN gene. Here, this is missense mutations are most commonly involved in hypertrophic cardiomyopathy. Another neat question. Okay, these genes encode proteins that form the contractile apparatus. Again, this is autosomal dominant. Even dilated cardiomyopathy was autosomal dominant, most predominantly. Now, what is the most important differentiating factor is? It is a disorder of the sarcomeric proteins. Now, another buzzword that you have to remember here is beta-myosin heavy chain. Okay, this is what is most frequently affected in hypertrophic cardiomyopathy. Another neat question. These are all buzzwords. Okay. Mutation in these three genes, that is beta-myosin heavy chain, myosin binding protein C, and troponin T. These account for 70 to 80% of all cases of hypertrophic cardiomyopathy. What is the morphology? It is marked by massive myocardial hypertrophy, without ventricular dilatation. इसमें कोई dilatation नहीं होता. There is disproportionate thickening of the ventricular septum relative to the left ventricular free wall. I'll tell you what it is. Asymmetrical septal hypertrophy होता है इसमें. Another buzzword. Asymmetrical septal hypertrophy. Okay. What happens is, I'll show you better. So now, this is normal heart. ठीक है? Normal heart है ये. Can you see the left ventricle? अच्छा खासा है उसकी size. Now look at here. This is hypertrophic cardiomyopathy. What is the meaning of asymmetrical septal hypertrophy? This is the septum. Look at the hypertrophy here and look at the hypertrophy here. Is it same? Is the hypertrophy on both the sides same? This has hypertrophied more than this. That's why it is called as asymmetrical septal hypertrophy. है ना? Because of this, the ventricular जो lumen है, that gets compressed, और ये जो बोलते हैं, इसको banana like configuration of the ventricular lumen बोलते हैं. ठीक है? It is not this. Many students have confused themselves कि इसको बोलते हैं, but this is the lumen that is called as banana like configuration, and this is the asymmetrical septal hypertrophy. Okay. The characteristic histological features are myocyte hypertrophy, haphazard myocyte disarray, and interstitial fibrosis. Again, similar thing. See, this is the histology. Here, can you see the enlarged nuclei and hypertrophied myocyte? Okay. And if you do a Mason's tricho, interstitial fibrosis will be seen. Similar. Okay. इसीलिए histology does not aid in the diagnosis of dilated or hypertrophic. It is mostly clinical. ये सारे pictures जो तुम देख रहे हो, these are all autopsy pictures. Okay. Usually we do not get heart biopsies like this for these conditions. What are the clinical features? As I told you, it affects young people, okay? It affects people who are attaining post-pubertal growth spurt. It is characterized by massively hypertrophied left ventricle, which paradoxically provides a markedly reduced stroke volume. Diastole में blood आने का जगह नहीं है, वो ठीक से contract कर नहीं पा रहा है, तो ejection fraction ऐसे ही कम होना है ना? So there will be reduced cardiac output and secondary increase in pulmonary venous pressure, back pressure increase होगा, which will cause exertional dyspnea and harsh systolic ejection murmur. What are the major clinical problems? Atrial and ventricular fibrillations, mural thrombus formation, thrombus इसमें भी form हो सकता है, okay? Infective endocarditis, heart failure, chronic heart failure, and sudden death. Sudden death is quite common in this condition. Most patients are improved by therapy that promotes ventricular relaxation. The treatment are partial surgical excision, controlled alcohol-induced infarction of the septal muscle. Alcohol inject किया जाता है so that the muscles get infarcted because there is hypertrophy. हमें muscle mass कम करना है ना? HCM is the most common cause of sudden cardiac death. In almost 1/3 of the cases of sudden cardiac death in athletes under the age of 35 is the underlying cause of HCM. Now the third type is restrictive cardiomyopathy. It is characterized by the primary decrease in the ventricular compliance resulting in impaired ventricular filling during diastole. ठीक है? इसमें कौन सा टाइप ऑफ डिस्फंक्शन होगा? Somebody said it. Diastolic. ठीक है? So this is the normal heart and look at this. इसमें उतना हाइपरट्रोफी नहीं होता जितना HOCM में होता है, ठीक है? But it is there and it causes the wall to become stiffer. Okay? So it can be idiopathic or because of systemic diseases, a part of systemic diseases like radiation fibrosis. Amyloidosis. Amyloidosis is one word that you have to remember for in the case of restrictive cardiomyopathy. Because of deposition of amyloidosis, it causes restrictive cardiomyopathy. All right. Sarcoidosis is another cause, and inborn errors of metabolism. Grossly, ventricles are mostly normal. Okay, they can be slightly enlarged. The cavities are not dilated, but the only difference is myocardium is firm. Biatrial dilatation is obviously present because ventricle fill नहीं हो पा रहा है, atrium is trying very hard, and that is why atrium dilation हो जाता है, both biatrial. Microscopic examination में again you will see increasing degrees of interstitial fibrosis, and biopsy in this condition can give us the etiological agent, like I told you, amyloid, okay, or sarcoidosis. So amyloidosis is caused by the deposition of extracellular proteins with the predilection for forming insoluble beta-pleated sheaths. Okay, so it can cause cardiac amyloidosis, systemic amyloidosis, or it can be restricted to the heart, particularly in the case of senile cardiac amyloidosis. इसमें कौन सा form of amyloid is deposited? Transthyretin. Okay, this is important that you have to remember. Okay, transthyretin is the type of amyloid that gets deposited in the senile cardiac amyloidosis. Now another one is endomyocardial fibrosis and Loeffler's endomyocarditis. Okay, these are the three causes of restrictive cardiomyopathy, even sarcoidosis. One condition in all three where biopsy is somehow confirmatory is restrictive cardiomyopathy. Okay, it will show the similar changes in HCM and DCM otherwise. So now coming to pericardial diseases, this is your competency. What is the etiology, pathophysiology, pathology, gross and microscopic features, diagnosis and complications of pericarditis and pericardial effusion. Pericardial disorders में दो चीजें आती हैं, effusions and inflammations. Okay, it can usually be associated with a pathological process elsewhere in the heart, surrounding structures, or secondary to a systemic disorder. Now what is pericarditis? Primary pericarditis is very uncommon. It can occur because of viral infection, or it can be because of bacterial, fungal, or parasites. Secondary causes is more common. Like you must have heard in the previous classes that acute MI का एक complication है pericarditis. Okay, so acute MI is the most common cause of pericarditis. Cardiac surgery, that syndrome is called as Tesla syndrome, where the pericarditis occurs after cardiac surgery. Radiation to the mediastinum for any tumors of the mediastinum. Okay, or processes that involve other thoracic structures. Uremia is a very important cause of pericarditis, and less commonly it can follow rheumatic fever, SLE, and metastatic malignancies. Pericarditis can cause immediate hemodynamic complications if it elicits a large effusion, resulting in a cardiac tamponade. It can resolve without any significant sequelae, or it can progress to a chronic fibrosing process. What is this condition called? It's when it progresses to a chronic fibrosing process. Constrictive pericarditis. Another important question in your NEET exam. Okay. Now, morphology depends on the cause. In patients with acute viral pericarditis or because of uremia, the exudate is fibrinous, which will impart an irregular shaggy appearance to the pericardial surface, which is also called as bread and butter pericarditis. Now you will hear this a lot. What is the meaning of bread and butter pericarditis? When you put butter in between bread and you remove it like that. Here is the picture. This is how it looks. See? It looks like that. And that is the reason why it's called as bread and butter pericarditis. In acute bacterial pericarditis, the exudate is fibrinopurulent, that is suppurative, often with areas of pus. Tuberculous होता है तो caseation necrosis होता है, malignancy होता है तो उसमें blood रहता है, metastasis भी होता है तो उसमें blood होता है. The exudates depend on what is the cause. If it's viral, it is fibrinous. If it is bacterial, it is fibrinopurulent. If it is tuberculous, there will be caseation. If it is malignancy or metastasis, you will have blood involved in the pericardium. Okay? And if with extensive suppuration and caseation, healing can cause fibrosis, leading ultimately to constrictive pericarditis. So this is the normal heart. ये cut section नहीं है ना? This is the intact heart, and this is your showing you pericardial constriction. This is the pericardium. ये normal pericardium के नीचे एक हल्का सा area दिख रहा है. This is the pericardium covering, and there is a little fluid normally present also. But when there is effusion or collection, fibrinous exudate in the pericardium, what it does, it reduces the capacity of the heart, है ना? Slowly जितना increase होता जाएगा उतना heart की capacity diastole होने में और systole होने में परेशानी करेगी. What are the clinical features? The patient can present with atypical chest pain which is not related to exertion or worse on recumbency, and a prominent friction rub that you will auscultate on the patient. ठीक है? The chest pain will be constantly present and there will be a friction rub present, prominent friction rub. Okay, when associated with significant fluid accumulation, acute pericarditis can cause cardiac tamponade, which will decrease the cardiac output and consequent shock. Cardiac tamponade में heart sounds are muffled when you auscultate. Okay. Now what is pericardial effusion? As I told you, normally pericardial sac में 30 to 50 ml of clear serous fluid is present. But when it is in excess and because of serous accumulation or fibrinous accumulation, it is called as pericardial effusion. What are the types? Serous, serosanguinous and chylous. Serous is because of, what are the causes? Congestive heart failure, hypoalbuminemia. Serosanguinous, it is because of trauma or malignancy or because of ruptured MI. And chylous, it is because of mediastinal lymphatic obstruction. What are the consequences? Depends on the volume of the fluid that is accumulated, the ability of the parietal pericardium to stretch. The latter depends largely on how fast the effusion accumulates. If it is a chronic accumulation, pericardium starts to stretch, it starts to accommodate. But अगर suddenly होता है, तो it cannot accommodate and then it affects the heart internally. So second वाले competency में क्या important था? What is the problem with both of you? Is it so funny? Is the class so funny? Constantly laughing. If it's so funny, we would like to share the joke. Please come. I'll give you the podium. Please come. Share the joke. We'll also have a hearty laugh. So funny everything is.